Nimmi Ramanujam. She is the Robert W. Carr Jr. Professor of Biomedical Engineering and Director of the Center for Global Women's Health Technologies. Nimmi is breaking new ground in expanding access to life-saving care. She and her team at Duke are working to invent new technologies that can bring cancer diagnosis and treatment to some women in some of the world's poorest communities. Please join me in welcoming Professor Nimmi Ramanujam.
Thank you, Vince, for the introduction, and it's really a pleasure to be here. I was at Penn for 4 years, so it's like coming back home. I would like to talk to you this evening about something my students and I think a lot about, which is global inequities in women's reproductive health. And my story begins with a remarkable woman, Henrietta Lacks, whom you may have heard of. Henrietta's cervical cancer cells were harvested when she died at the age of 31. And these cells have revolutionized medical research over the last 100 years. During Henrietta's life, cervical cancer was a death sentence. But today, it's actually a cancer success story. Because of advances in screening, diagnosis, and treatment, this is actually one of the rarest cancers in countries like the United States. Again, an encore. In fact, the slides have yet to change. There we go, third time's a charm. So in fact, the incidence of cervical cancer has dropped by 70% over the last 70 years, and this is largely attributed to 3 key innovations. Papanicolaou developed a cancer risk test that many of you know as the Pap smear. Hinzelman developed a low-power microscope called the colposcope, which looks at abnormal changes in the cervix before it becomes cancer. And Zurhausen made that key connection between the HPV virus and cervical cancer, which has paved the way for a more sensitive cancer risk test and has led to a vaccine that can prevent cervical cancer altogether when it's administered to adolescents and young adults. Ironically, however, women in less affluent communities like Harriet, who lives in Zambia, have the same chance of getting cervical cancer in their lifetimes as Henrietta did a century ago. As Henrietta, more than 50% of women who get cervical cancer today are less than 35 years of age. So the question is, why have our innovations, our life-saving innovations for cancer prevention, not translated to reduce deaths from cervical cancer in the poorest countries in the world? And this picture says it all. So this is the Jengo Clinic in Moshi, Tanzania, and you can see that there's no shortage of women coming to the clinic. But if you look at the gynecology suite, there's no colposcope or any infrastructure to support an HPV test or a Pap smear. These technologies are simply unsustainable in these settings. But now there's actually political will. The Director General of the World Health Organization announced a call to action to eliminate cervical cancer as a public health problem. There is no better time than now to make sure that every woman has access to life-saving technologies that can prevent her from dying from this disease. To address this pressing challenge, it's simply not enough to do business as usual. You really have to disrupt the way things are done and make those things obsolete. And there are many examples of this in the consumer industry, such as Uber, but very few in the medical device industry. Why not? I believe this is because many innovations make hospitals better, but hospitals are inaccessible to many. So if we want to prevent cervical cancer, we need to create innovations like Uber, where nurses and midwives in community clinics can do what gynecologists in hospitals normally do. The best way of preventing cervical cancer is to find it before it becomes cancer. Remember the colposcope invented by Hinzelmann? It's a pretty large device. It's about as tall as I am. It requires specialized parts, maintenance, electricity, and an expert to operate it and to interpret the images that it captures. What makes colposcopy cumbersome and costly is the distance, it's about a foot, that needs to be maintained between the viewer and the cervix. How can you apply the Uber model to colposcopy? Think spy pen. It's a regular pen that has a digital camera and a USB charging port, and a slender form factor that allows it to be inserted through narrow openings through the speculum. And the idea of the spy pen is what led to the design of what we call the pocket colposcope, which is now an FDA-cleared product. Like the spy pen, the pocket colposcope is small enough to fit in a coat pocket, runs off a cell phone battery, and yes, it fits through a speculum. But what's really important is that the pocket colposcope provides all of the capabilities of a conventional colposcope, and it's rugged enough to work in a hot and humid environment like the body cavity. And so I just wanted to show you what the pocket colposcope looks like, and it literally, aside from the little cables that follow it, basically is a portable device that you can take anywhere to do cervical cancer diagnostics. When it comes to the pocket colposcope, cheaper is actually better. The pocket colposcope dramatically improves contrast and magnification over a conventional colposcope. So it's actually better at finding precancerous lesions compared to traditional technologies. When coupled with artificial intelligence algorithms, the pocket colposcope can serve as a virtual expert and bring an immediate diagnosis to a patient that is in a community setting without the need for a gynecologist. No offense to any of the gynecologists in the room. We have shown that our algorithm is actually superior to 3 expert gynecologists who have a collective experience doing colposcopy of more than 100 years. The pocket colposcope is actually very easy to use. If you've used a digital camera, you can use the pocket colposcope. And so here's a midwife in a mobile clinic in the outskirts of Lima, Peru, testing it on the model of the cervix. With the pocket colposcope and the artificial intelligence algorithms, she has all the tools she needs to bring cervical cancer diagnostics for the women in her community. Leveraging the Uber model to bring colposcopy to the hands of midwives, nurses, and community health providers can create more access to cervical cancer prevention globally. We've implemented the pocket colposcope in over 1,000 patients in 8 countries across the globe. But we weren't satisfied. The next challenge for us was to bring the concept of self-driving cars to the practice of colposcopy. In other words, could we build a pocket colposcope that a woman could use herself? We know that this would actually be impactful because it would reduce the resources needed for cervical cancer prevention, and it would finally give women privacy and autonomy over their own health. So how did we do this? First, we had to look at the elephant in the room. And in this case, at least 50% of you probably know what I'm talking about. In order to implement the concept of self-driving cars, we needed to completely rethink the speculum. So more props to show you. So this is the speculum. It's an instrument. It's a beautiful instrument, actually, which gives doctors a line of sight to the cervix. Inserting the speculum requires training and experience, especially if you have to nudge the cervix into view. And I will say, and the reason I say this is a beautiful device, in that what I mean by that is that it does its job really well. There have been many efforts to redesign the speculum, but they have all failed, which is why when you go to a gynecology exam and you know who you are, this is what you will see or feel. The pocket colposcope presented a unique opportunity to create a speculum-free alternative. We knew we had to do this if we wanted to give women the opportunity to do their own exam, to implement their own self-driving vehicle. This time, we were not inspired by the spy pen, but actually by the shape of a calla lily. What if you could replace the blades of a speculum with the petals of a calla, the stem of the calla with the pocket colposcope, and the eyes, the human eye, with a cell phone? That led to the design of the coloscope. And here's a video of a woman doing her own self-exam with the coloscope. She's able to insert, manipulate, and view her cervix in a matter of seconds, and more importantly, in the comfort of her home. Today, more than 75 women have used the coloscope, and there's no question that they would much rather have a coloscope exam over a conventional gynecological exam. But the coloscope has become more than a technology for cervical cancer screening. It has become a vehicle for storytelling, and one that allows women to have new perspectives of their own bodies through written expression. And here is one reflection that I'd like to read to you. When I think of the female reproductive anatomy, I think that it's enigmatic, that it's hidden from us physically. But it's also kind of hidden in the way that we don't talk about it. So this was kind of an eye-opening experience to be able to visualize something that is so intrinsically a part of me that I've never seen it in this way before. I think many women don't realize this is a part of them. These reflections became the inspiration for an inaugural art exhibit, which brought together the collective voices of coloscope users as well as artists from around the globe to reflect on their own personal stories with their invisible organ, the cervix. We were struck by the candor of not only the artists, but also the visitors who used the safe space to share the shame and stigma they felt when thinking about their bodies and their health. I'd like to take a pause here and go back 70 years. This is a picture of Ava Peron, the beloved First Lady of Argentina, who died of cervical cancer at the age of 33. Her diagnosis was concealed from her and the public because it was a disease that carried with it shame and stigma. The art exhibit reminds me that we may be still struggling to break away from the past, from the shame and stigma that's often associated with women's bodies and their reproductive health. How can a woman feel comfortable talking about her body and advocating for life-saving innovations built at Duke University if we as a society are not? We must find a way towards unlearning our stigmas and biases around women's bodies and reproductive health, and need more safe spaces to do that. How are we doing it? We have created a platform called the Kala Campaign, through which we are curating authentic stories on the historical, cultural, and social perspectives that have shaped and are continuing to shape women's reproductive health. I know each and every one of us has a story to share, and I really hope that you will share yours with us. Thank you.
Thank you so much, Nimmi. That was a wonderful talk, and again, we'll open the floor to questions, as we did earlier. And while you're thinking, let me ask a quick question. How are students engaged in the work that you're doing? How do they learn about your research and your projects, and how do they become involved?
So I am an engineer, but everything that I have done has required us to reach out to every little nook and cranny at Duke. And I kid you not, there are days when I'm a social scientist. I'm not really. And there are days when I feel like I'm working on health policy. And the point is, when you go to every nook and cranny at Duke, there are students looking for opportunities that allow them to get outside of their comfort zone. So you made a point, President Price, about how when you're on the fringe, that's education. And I think our students believe that when they're on the fringe, that's education. And this is really a way for us to bring so many different elements at Duke together to address a contemporary issue. But at the same time, if you're an engineer, you can be comfortable building things. But technology is not limited to engineering. It can be a conversation starter that gets into many different realms within our community.
Right. Questions? Questions from the floor. We have one over here.
Thank you very much. Has the Duke University Medical Center been embracing this product and using it in the hospital and at the Student Health Center at all?
That's a great question. So yes.
Thank you.
Can I tell you a funny story if I have time? So the reason that we're doing this campaign is for a good reason. So the pocket colposcope, everyone loves it. It's all over the world and people get it, and I always get people to ask me to talk about it. And then we invented the Coloscope, and I found out that we hit this virtual wall, which was, my patients don't feel any pain. So I think that's what made us realize that you can, just because you build it, that doesn't mean they will come. And so, and it's not to say that we need to tell people what to say, but simply to understand what the trepidations are and how we can have a new conversation that would allow us to bring these kinds of technologies, these user-initiated interventions, to the global community. And that's actually why we had the art exhibit, because it created a space where doctors, students, scientists, everyone, the provost, maybe I shouldn't go that far, was able to speak candidly because they felt that they were in a space, maybe a vacuum, where they could talk freely about what the sort of dialogue in their head is when they're thinking about these changes that challenge a status quo. So that's a great question. The Wellness Center asked us to put the art exhibit there for the next 3 months, so that's a step in the right direction.
Question in front here? Yeah.
What about access? I mean, this is bringing access out to areas all over the globe, but you also need basic access to like electricity and whatever in order to do. There's so many places in the world that don't even have that basic access. How do you?
That's right.
That?
And so everything we develop is what I call human-centered design, women-centered design. So we go to those communities and try to understand fundamentally what the constraints are and then we bring that back to Duke, and that's what dictates what we do. You're right, many places in the world don't have access to basic resources. So I will tell you that some of those constraints, I don't know if I can say this, but beat the crap out of engineering. In other words, we have to really challenge ourselves. Our work is hard because if you have to build something to work in those conditions, and sometimes those conditions are pretty extreme, then you can actually build something robust that can work at home. So it's an amazing opportunity to really stretch our imagination and think about how we can remake history.
And if I could add as well, as part of the energy initiative at Duke, which pulls together faculty and students from around campus, we've launched an energy access initiative, which really is focused on how we can bring energy to underserved parts of the world. And that's working at the intersections of the Pratt School and the Nicholas School, for example. We have a question here in the center. And then I'll turn to this side of the room shortly, so think about it.
Thanks, how you doing? So first of all, you guys designed the whole thing at Duke?
Yep, everything.
Okay,
in fact, even the FDA clearance was done by Duke students.
Is it built there too?
We outsourced the design, the actual looks like, to an industrial design company, but it was all funded by Duke.
So I belong to a Rotary Club, and we obviously help a lot of places around the world. People don't have a lot of, obviously, like they're saying, electricity and so forth. So the pocket colposcope.
The pocket colposcope?
$. The other one, I mean, I thought the regular the colposcope was $500, the one that you made.
Yep.
Then the new one, the caloscope.
It's about half of that.
That's about it. But still $250 to do a self-examination that, how many people get cervical cancer?
500,000 women.
Right. But I mean, is that cost, I mean, you have to bring that down to make it accessible to the rest of the world.
Yeah, in fact, if so you're talking about cost, which is probably something that goes beyond what I can say on the podium, but very quickly, technology is actually the cheapest part of the equation. It's human resources. So whatever you can do to bring down the cost of labor or the amount of labor that's needed will actually be more economical. So that's the first thing.
So it's not expensive to build.
It's not expensive to build it. It's not expensive to deploy it. I think what's really expensive is overcoming the inertia to give people autonomy to do the test themselves. That requires health policy.
Cool, thank you.
We have time for perhaps one more question from, yes, this side of the room. Sure.
This is really fascinating. I'm curious if your scope is, the next level is implementing like intervention. So like LEAP that could be done with it, or even just biopsy or cryosurgery or something like that.
Yeah, so thank you for that question. I'm not going to use the great question because I think that I need to come up with something creative, right? We're at Duke. We are actually working on something to address that challenge. So I just want to give this number out because I think it's very important. 9 out of 10 people in low resource settings don't have access to essential surgery. So it's really unethical to develop a diagnostic without a treatment. There is cryosurgery, but it works for a small portion of those precancerous lesions. What if a woman has cancer? What do you do? So we've actually developed a therapeutic that uses booze, alcohol, ethanol, whatever you want to call it. And then ethanol is actually not very effective. It's actually been used for inoperable liver cancer. But what we've done is we've mixed it with something that's used in pharmaceutical called ethyl cellulose. And when you inject it, it actually creates a gel. So we call it a jello shot. And what it does, it completely dissolves the tumor. And that's our next innovation in the pipeline, because if a woman is going to be diagnosed with cancer, we've got to, have her back.
Well, please join me again. Thank you, Nimmi.